Franca will give a talk about liver intervention, and I'm very sure that we'll have got an excellent talk and see all great images we will ever offer us every time, Franca.
Today, my presentation is about the technique of percutaneous ablation of a liver lesion, including radiofrequency, microwave, and electroporation. Percutaneous ablation therapies are procedures widely used for liver tumors, primary and secondary liver tumors. And during the procedure, a needle device is inserted under ultrasound or CT guidance, delivering energy directly in the tumor. Radiofrequency is the most common used comparing with and known comparing with the most recent microwaves. And electroporation is a new emerging no-thermal therapy. Why percutaneous approach? Because it is minimally invasive with a low complication rate, good efficacy, and repeatability. In the literature, the ablation procedure reported a very good survival in the patient treated. The primary goal of ablation procedure is to destroy all viable tissue, viable malignant tissue, including at least of 0.5 millimeters for HCC and 1 centimeter for metastasis of ablative margins of normal tissue to obtain safety margins and reduce the possibility of recurrence. The physical properties of both radiofrequency and the microwave are different. Radiofrequency uses electromagnetic energy. We have a heat propagation in centrifugal direction from the probe to the periphery, and also the temperature decrease from the probe to the periphery, with effective result for lesion up to 3 centimeters, but worse results in lesion more than 3 centimeters. Microwave uses electromagnetic field with a centrifugal ablation and homogeneous heating in the tumor. The main difference between microwaves and radiofrequency heating is that microwave heating is happened in a volume around the applicator antenna, while radiofrequency heating is limited to areas of high current density. And when this current density reduces, we have a plateau with the inefficacy of the treatment. Radiofrequency required electrical conductive path, not necessary for microwaves, but microwaves are capable of propagating through materials with low or zero conductivity. Radiofrequency demonstrated in the last 20 years results against liver tumors up to 3 centimeters, with improvement of local recurrence in lesion more than 3 centimeters. And the microwave system can create a larger ablation zone than radiofrequency. And this is in the lab, but in the clinical practice, of course. So this is a small lesion, a small HCC treated with the radiofrequency 10 minutes, and the 10 minutes of a microwave application in a HCC of 3 centimeters. The difference is very evident. The necrosis is similar for both applications. We have a necrosis, a coagulative necrosis, and it's very easy to recognize, of course, in the pathological aspect. This is the necrosis corresponding with the black in using contrast enhanced ultrasound just after treatment, and this is the inflammatory ring around the necrosis, and the same is visible in CEUS. But microwave can obtain this larger necrosis faster, hotter, and with larger area of treatment. It's very important always the shape of thermal lesion. is with microwaves we can obtain spherical morphology of the ablation, or with the one insertion, or with the multiple insertion, but which work in simultaneous, because in sequential insertion we have a Mickey Mouse aspect with risk for satellitis recurrence. Another important things for the ablation treatments is the tissue contraction, much more strong for microwave than for radiofrequency. You can see in this lab test, we inserted markers in the tissue before ablation, and the distance is of 4 centimeters. When we start with the ablation, you can see that the tissue contraction reduces this diameter, and we arrive at 3 centimeters. But inside these 3 centimeters is included the 4 centimeters of the tumor. Probably microwave can help us to break the limits of the 3 centimeters of radiofrequency. The main clinical indications are for hepatocellular carcinoma and colorectal liver metastasis. About hepatocellular carcinoma, the EASL practical guidelines considered radiofrequency for single HCC less than 3 centimeters as a first-line option, leaving surgery for those patients with nodules not suitable for radiofrequency or who failed treatment. But it's very important to obtain a complete radiological response immediately. It means after the first treatment, because this can improve the survival and reduce the aggressiveness of the tumor and the tumor spreading through the portal system. In this tab, long-term results of radiofrequency for HCC inside to the Milan criteria are reported. And the complete response is obtained in these papers from 90% to 99.4%, very high, with a local recurrence ranging from 3.2 to 32%, and the distant recurrence between 58 to 81%. The overall survival after 5 years is ranging between 40% to 67%. Morbidity and mortality are very low comparing with the surgery. But why can microwave improve the results of radiofrequency? Because of a faster ablation, larger ablation zone, higher temperature, less sensitivity to tissue impedance and the ink-sink effect of the blood vessels, and increased predictability. The less sensitivity is because of a short, higher temperature and a short ablation. The increased predictability is because of the unaffected by changes in the tissue environment. So in the translation in clinical effects is that we can decrease the number of sessions and shorter treatment times with very benefits for the patient. This is a case sorry, of HCC in a bad position location closer to the vena cava and the hepatic vein. This is the needle inserted inside to the lesion, and this is the result after 1 year without recurrence. This is a large lesion of HCC 4 centimeters treated with one insertion of microwave for 10 minutes with 60 watts, and it's very clear the antenna inside to the tumor. And this is the result 24 hours later, and after 4 years it is very difficult to detect the lesion. In the literature, is reported that the comparison of results from radiofrequency versus microwave in HCC, including meta-analysis. And the conclusions are that microwave and the radiofrequency have been reported equivalent results in terms of therapeutic effects, overall survival, and complication. And in the cohort studies, sorry, local tumor progression is a little bit better for microwave group, but the difference is not statistically significant with the radiofrequency. So the conclusion is that in single HCC less than 3 centimeter, microwave may be recommended over radiofrequency because of its short treatment time. About liver metastasis, ESMO recommendation for local ablation is for patient with unresectable liver metastasis only, or oligometastatic disease, and the decision should be taken by a multidisciplinary team based on local experience, tumor characteristic, and patient preference. And we can use radiofrequency in addition to surgery with the goal of eradicating all visible metastatic sites. In this position paper, which reported that the result of thermal ablation of colorectal liver metastasis are sublined the right parameters to obtain good results. Tumor size less than 3 centimeter, tumor number less than 3, avoiding avoiding risk structure. And in terms of mortality, major complication, and the hospital stays, percutaneous radiofrequency has a very low percentage. This is another example of metastasis of 3 centimeter in a very bad position for radiofrequency and for surgery. We treated with one insertion of microwave, and the results after 8 months is is this one with a spherical ablation without recurrence. In this table are reported the outcomes in colorectal liver metastasis after radiofrequency and microwave. And you can see that the local recurrence rate is very low for the group treated with microwaves than this with radiofrequency. In conclusion, microwave demonstrated significantly improved the local tumor control compared with radiofrequency. Irreversible electroporation is a non-thermal tumor ablation using a high voltage electric pulse, and is used in solid tumors, increasing the membrane permeability of cells. The advantages of this treatment is limited the risk of thermal injury to neighboring critical structures, unsensitive to heat sink effect, and other advantages of multibipolar mode. The limitations are that we have very few long-term data regarding the safety and efficacy, and it is considered a niche technology therapy for a small lesion not treatable with radiofrequency or microwave because of the risk structure. General anesthesia is absolutely mandatory using curare and major analgesics drugs. So for ablation procedures, there are must be considered the risk condition, but we have two groups: a true risk condition and a false risk condition. The true risk condition are the low conspicuity at ultrasound, so we can change our imaging modality to guide using ultrasound contrast agents, using fusion. The liver function, the risk structure, the presence of a pacemaker if we use monopolar radiofrequency, but if we use bipolar radiofrequency or microwave, no problem for the pacemaker. The platelet disorder and the biliary anastomosis or sphinctectomy because of the risk of abscess for this in these cases. Are false risk conditions the position in subcapsular location, subdiaphragmatic, gallbladder, heart, because many papers are published demonstrating that these are not true risk conditions. The influencing factors for success are selection of the patient within a multidisciplinary team, size, site, lesion conspicuity, and for this reason we can use contrast and ultrasound, tumor-free margins, skill of the center, and follow-up imaging. You can see that contrast and ultrasound can be very useful to detect a small recurrence, like in this case, with this small button inside to the necrosis of HCC, demonstrating a local recurrence. In summary, in the field of ablative therapies, the equipment available today is extensive. We have many choices of ablation. Each patient must be evaluated on the basis of both clinical and tumor features within a multidisciplinary team. Microwave is as safe and effective as radiofrequency for treating liver cancer, demonstrating a reduced local tumor progression. About electroporation, we wait larger clinical trials to understand how to use it. Thank you very much for your attention.
Dear Franca, great talk. Are there any questions from the audience? I haven't received any question until now. Okay, thanks for a great talk. So we just have to one final speaker.